Good morning, students. Today we will see some of the drugs which commonly used in obstetrics. The drugs the first one is oxytocics. The drugs that have power to excite uterine contractions of the uterine muscles. The important and commonly used drugs are oxytocin, ergot derivatives, and prostaglandins. First one is oxytocin. This is in hypothalamus and stored in the posterior pituitary. It has a half-life of 3 to 4 minutes and a duration of action of approximately 30 minutes. The preparations use pitocin or syntocinon, that is 5 international units per ml, syntamatin, that is syntocinon 5 units, and ergometrin 0.5 mg, and oxytocin nasal solution, that is 40 units per ml available. So in the first trimester, uterus is almost refractory to oxytocin. The second trimester, relative refractoriness persists, and such oxytocin can only supplement to other abortifacient agents in induction of labor. In later months of pregnancy and during labor in particular, we are highly sensitive to oxytocin even in small doses. Oxytocin loses its effectiveness unless preserved at the correct temperature, that is between 2 degrees Celsius to 8 degrees Celsius. Action. It acts directly on microfibrils producing uterine contraction and stimulate milk ejections by the breast. Myometrial oxytocin receptor concentration increases maximum, that means 100 to 200-fold during the labor. Oxytocin acts to the receptor and voltage-mediated calcium channels to initiate myometrial contractions. It stimulates amniotic and decidual prostaglandin production. Bound intracellular calcium is eventually mobilized from the sacroplasmic reticulum to activate contractile protein. The uterine contractions are physiological, that is, causing fundal contraction with the relaxation of the cervix. Oxytocin may be conveniently used in pregnancy, labor, or puerperia. The indications are grouped as follows. First one is therapeutic. It can be divided into during pregnancy and labor and puerperia. Then diagnostic include contraction stress test and oxytocin sensitivity test, otherwise known as OST. Indications during pregnancy include early pregnancy to accelerate abortions that are inevitable or missed and to expedite expulsion of herediform mole, to stop bleeding following evacuation of the uterus, use an adjacent to induction of abortion along with other abortifacient agents like PGE1 or PGE2. In late pregnancy, it can be used to induce the labor, to ripen the cervix before the induction, for the augmentation of labor, and for uterine inertia. During labor, in uterine inertia, to prevent and treat postpartum hemorrhage, for augmentation of labor, in active management of third stage of labor following expulsion of placenta as an alternative to ergometrin, and during postpartum to initiate milk letdown reflex in the breast engorgement and to minimize blood loss and control of postpartum hemorrhage. The contraindications of oxytocin during pregnancy include grand multipara, contracted pelvis, history of cesarean section or hysterectomy, malpresentation. In labor, all the contraindications in pregnancy, along with that obstetrical labor, incoordinate uterine contraction and fetal distress. At any time, it include hypovolemic state and cardiac diseases. Maternal complications include first one is uterine hyperstimulation. It is frequently observed as a side effect. There may be excessive duration of the uterine contraction or increased frequency of contractions. It is often associated with the abnormal fetal heart rate pattern. Second is uterine rupture. May be seen with violent uterine contractions common. High-risk cases are grand multipara, malpresentation, contracted pelvis, prior uterine scar like hysterectomy, and excessive oxytocin use. Water intoxication is due to antidiuretic function when used in high doses. Water intoxication is manifested by hyponatremia, confusion, coma, convulsions, congestive cardiac failure, and death. It is prevented by strict fluid intake and output record, use of salt solutions, and by avoiding high dose of oxytocin for a long period of time. Hypotension. Bolus IV injections of oxytocin can cause hypotension, especially when the patient is hypovolemic or with a heart disease. Occasionally, oxytocin may produce anginal pain. Then as a antidiuresis, antidiuretic effect observed when the oxytocin infusion rate is very high. Fetal complication, first one is fetal distress, fetal hypoxia, or even fetal death may occur due to uterine hyperstimulation, uterine hypertonia, or polycystic causes reduced plasma blood flow. Route of administration include controlled IV infusions or nasal spray for milk ejection. Method of administration. The main principles, because of safety, the oxytocin should be started with a low dose and escalated to the interval of 20 to 30 minutes where there is no response. When the optimal response is achieved, optimal response means uterine contraction sustained for 45 seconds and numbering 3 contractions in 10 minutes. Administering a particular concentration in ml per international unit is to be continued. This is called oxytocin titration technique. Second, the objective of oxytocin administration is not only to initiate effective uterine contractions but also to maintain the normal pattern of uterine activity till delivery and at least 30 to 60 minutes beyond that. For induction, oxytocin should start with low dose. Optimal response is achieved. An observation which we have to make during infusion include rate of flow of infusion, uterine contraction, that means number of contractions per 10 minutes, duration and relaxation noted, fetal heart rate monitoring every 15 minutes, and assessment of progress of labor, that means descent of head and cervical dilatation. Regulation of the trip. The trip is regulated by either manually counting the drops per minute commonly practiced or can be infusion pump. Indication for stopping the infusion include nature of uterine contractions like abnormal uterine contractions occurring frequently every 2 minutes or less or lasting more than 60 seconds. Evidence of fetal distress and appearance of untoward maternal symptoms. Diagnostic use of oxytocin. The contractions tested oxytocin challenged us to determine the respiratory function of fetal-maternal placental unit during the contractions when the blood flow through the unit is decreased. The possible candidates include patients who have IUGR, post-maturity, hypertensive disorders of pregnancy, and GDM. Contraindications include compromised fetus, previous history of cesarean section, complications likely to produce preterm labor, and APH. Procedure. The oxytocin infusion is started in the same manner as mentioned earlier. The initial rate of 1 ml unit per minute is stepped by intervals of 20 minutes until the effective uterine contraction are established, and any alteration in the FHR during contraction is recorded by electronic fetal monitoring. Alternatively, clinical monitoring can effectively perform using hand to palpate hardening of the uterus during the contraction and auscultation of FHR during contraction and for 1 minute thereafter. It takes at least 1 to 2 hours to perform the test. Interpretation. If it is positive, means persistent late deceleration of FHR. Negative means non-late deceleration or significant variable deceleration. Suspicious, inconsistent but definitive deceleration do not persist with most uterine contraction. Unsatisfactory, poor quality of recording or adequate uterine contractions not achieved. Hyperstimulation, deceleration of FHR with uterine contraction lasting more than 90 seconds. Importance. A negative test associated with a good fetal outcome, whereas a positive CST indicate the patient increased evidence of IUD, fetal distress in labor, and low UPGAR score. But 50% of chance of false positive result, such as positive test cases, are subjected to other methods of evaluation for the well-being of the fetus. Suspicious test should have a repeat at the test in the 24 hours. Second is ergot derivatives. Commonly used drugs are ergometrin 0.25 mg and methergine 0.2 mg. It acts directly on myometrium to stimulate the uterine contractions and decrease bleeding. Ergometrin is an alkaloid isolated by Dudley and Moore in 1935 from an ergot, a fungus Clavicus purpura that commonly in the cereals like rye, wheat, etc. The alkaloids are detoxified in the liver and eliminated in the urine. Methergine is a semi-synthetic product derived from lysergic acid. The mode of action. Ergometrin acts directly on myometrium. It excites uterine contractions which come so frequently one after another with increasing intensity that the uterus passes into the state of spasm without any relaxation in between. The effectiveness: keeping the physiological function in mind, it should not be used in the induction of abortion or labor. On contrary, it is highly effective in hemostasis to stop bleeding from the uterine sinuses either following delivery or abortion. Methogen is somewhat slower in producing uterine response, taking 96 seconds in contrast to 55 seconds by ergometrin when administered intravenously. Mode of administration: ergometrin and methogen can be used parenterally or orally. As it produces tetanic uterine contractions, the preparation should only be used either in the late second stage of labor, after the delivery of anterior shoulder, or following delivery of the baby. Sindometrin should always be administered intramuscularly. Therapeutics: to stop the atonic uterine bleeding following delivery, abortion, or expulsion of hiatus or more. Prophylactically, against excessive bleeding, it is administered after delivery of the anterior shoulder. Contraindication: organic cardiac disease, PAH, Rh negative mother, and in multiple pregnancy, it is given only after delivery of the second baby. Indications: therapeutic indications are there, and contraindications: prophylactic, like suspected plural pregnancy, it is given accidentally if the delivery of the first baby. Second baby will be compromised. Then organic heart disease, severe preeclampsia, Rh negative mother. Then there is a comparison between ergo derivatives and oxytocins. Then the side effects of ergometrin include nausea and vomiting. It may precipitate hypertension. Prolonged use lead to gangrene of toes and interfere with lactation. It should not be used during the pregnancy, first stage, second stage, prior to the crowning of the head. The third one is prostaglandins. Prostaglandins are the derivatives of prostanoic acid, from which they derive their names. They have a property of acting local hormones. Prostaglandins were first described by name by von Buehler in 1935. The preparations used are PGE2, that is prostin E2 dinoprostone, PGF2 alpha, and PGE1, that is misoprostol. Actions: both PGE2 and PGF2 alpha have oxytocic effect on pregnant uterus. Chemistry: prostaglandins are 20-carbon carboxylic acid with a cyclopentane ring which is formed by polyunsaturated fatty acid. On many varieties of prostaglandins, PGE2 and PGF2 alpha is exclusively used in clinical practice. The subscript numerical after the letter indicate the degree of unsaturation. Inactivation is done in lungs and liver. The sources are prostaglandin synthesized from one of the essential fatty acid, arachidonic acid, which is widely distributed throughout the body. In female, these are identified in menstrual fluid, endometrium, decidua, and amniotic membrane. Prostaglandins: increasing biosynthesis of PGs of E and F series in the uterus is a prerequisite for labor, both term and preterm. PGs are the paracrine autocrine hormones, as they act locally at the site of production. The half-life is peripheral circulation is about 1 to 2 minutes. Decidua is the main source of PGF2 alpha. Fetal membrane amnion produces PGE2, and myometrium mainly produces PGE1. In vivo, PGF2 alpha promote myometrial contractility. PGE2 induce labor with cervical effacement and dilatation. It shortens the induction to delivery interval. PGs promote myometrial contractions irrespective of duration of gestation, whereas oxytocin acts predominantly on the uterus at the term or in labor. This has helped the widespread use of PGs to affect the first trimester medical termination of pregnancy and also for induction of labor at term. Side effects of prostaglandins are less when used vaginally. Local application of PGE2 gel is gold standard for cervical ripening. The indications are induction of abortions during second trimester and expulsion of hiatus or more, for induction of labor in IUD, for augmentation or acceleration of labor, to stop bleeding from open uterine sinuses, and cervical priming. Contraindications include hypersensitivity, uterine fibrosis, cervical stenosis, pelvic inflammatory disease, and respiratory disease. The side effects are headache, dizziness, hypotension, joint swelling, and blurred vision. Mechanism of action: both PGE2 and PGF2 alpha have got oxytocic effect on pregnant uterus as when used appropriate dose. The probable mechanism of action is the change in myometrial cell membrane permeability and/or acceleration of membrane-bound calcium. Prostaglandin is also sensitized to myometrium to oxytocin. PGE2 is at least 5 times more potent than PGF2 alpha. PGF2 alpha predominantly on myometrium, where PGE2 acts mainly on cervix due to its collagenylytic property. PGE2 causes dissolution of collagen bundles and increased submucosal water content of the cervix. The advantage and disadvantage of prostaglandins. The preparations prostaglandin E2 is widely used because of less toxic and more effective in PGF2 alpha. However, it is more costly. Vaginal tablet contains 3 mg of dinoprostol in the posterior fornix, followed by 3 mg after 6 to 8 hours, maximum 6 mg. Vaginal pessary releasing dinoprostol approximately 10 mg over 24 hours. It is removed when cervical ripening is adequate. Prostin E2 gel 500 microgram to cervical canal below the level of internal os or 1 to 2 mg in the posterior fornix. Parenteral PGE2 prostin E2 containing 1 mg per ml and PGF2 prostin F2 alpha containing 5 mg per ml and methyl analog of PGF2 alpha carboprost containing 250 microgram per ml. PGE2 effective for induction of labor causing cervical effacement and dilatation. It reduces the need for oxytocin use and cesarean delivery. PGE2 preparations are relatively expensive and require refrigeration, otherwise it becomes unstable at room temperature. Methyl ester of PGE1 misoprostol. It is rapidly absorbed and more effective than oxytocin or dinoprostol for the induction of labor. Misoprostol has been used for cervical ripening. Primarily, it has been used for peptic ulcer disease. Transvaginal misoprostol is used for induction of labor. Oral misoprostol can be used as a convenient to the patient. Given 25 to 50 microgram every 3 to 6 hour oral or vaginal route. Low dose of oral PGE1 also can be given. It is to be repeated in the interval of 2 hours. Buccal or sublingual misoprostol also used for induction of labor and vaginal delivery. Oxytocin when needed may be after 4 hours. Misoprostol have been found to be effective as PGE2 for cervical ripening and for induction of labor. Advantage of PGE1 over PGE2. Misoprostol is cheap, stable at room temperature, long shelf life, easily administered, that means oral, vaginal, or rectal, and has less side effect. Induction of delivery interval is short and need of oxytocin augmentation is less. Failure of induction is less. Antihypertensive therapy. The first line therapy is methyl-dopa and labetalol, and second line of it is the nifedipine and SC inhibitors and are avoided in the pregnancy. We can see about magnesium sulfate. The multiple conditions treated in the obstetrical setting with magnesium sulfate including preterm onset of labor, pregnancy-induced hypertensive disorders, management and prophylaxis of seizures. Mechanism of action is an anticonvulsant. At the same time, it's a small effect on the hypertensive, but its main action is anticonvulsant. The adverse reaction, that means the signs of magnesium sulfate toxicity, we can write in synonyms like burp, that B means BP decrease, urine output decrease, respiratory rate decrease, and patellar reflex is absent. These are the signs of magnesium sulfate toxicity. Side effect of vasodilatation: feeling of warmth, lethargy, facial flushing, hypotension. Other side effects include sweating, diminished reflex and confusion, intense stress. The pharmacokinetics: IV absorption is complete, bioavailability, onset is immediate, and duration is almost 30 minutes. Dosage: 4 gram loading dose and 1 gram per hour, 4 gram loading dose and 1 gram per hour continuous maintenance infusion, or 4 gram IV and 10 gram IV loading dose and 5 gram IV IM maintenance dose every 4 hours regimen. Contraindications include renal failure, myasthenia gravis, and myocardial ischemia or failure because of its depressive effect on respiratory and cardiac function. Monitoring an antidote: respiratory rate should be 16 burp per minute and deep renal reflex normal prior to initiating magnesium sulfate therapy. Urine output during the treatment should be at least 25 ml per hour. Half of the dose of magnesium sulfate should be given if at least 100 ml of urine is produced in 4 hours. Fetal heart rate should be closely monitored while treating the mother with magnesium sulfate. Antidote is calcium gluconate. Magnesium sulfate is most effective remedy in the history of treatment of eclampsia. Serum concentration is between 2 and 3.5 millimole, that is 4 to 7 milliequivalent per liter, are generally held to be therapeutic. Thank you. Thank you for listening.